Today, in What's New in 22Q, we are taking a deep dive into some really crucial recent findings. We're looking at otolaryngologic, or ENT, that's ear, nose, and throat challenges, specifically within the 22Q 11.2 deletion syndrome population.
And we're not just looking at one snapshot in time.
No, not at all. Our mission today is to follow the thread of these issues across the entire lifespan. So, from the frequent struggles of early childhood right into the complex and, well, often overlooked, health challenges faced in adulthood. Okay, let's unpack this.
And we really have to.
This topic is just so critical because ENT issues are foundational. They're fundamental to how an individual communicates, how they learn, even how they sleep.
Absolutely.
Persistent problems like ear infections, chronic fluid, speech development hurdles, and even subtle airway issues. I mean, these are among the most frequent clinical battles that individuals and families living with 22Q 11.2 DS encounter.
They really are.
And if we can understand these issues better, we can profoundly improve quality of life and communication.
What's fascinating here, and what the new data really highlights, is seeing how the clinical picture transforms over the decades. It shows a clear evolution.
An evolution, right?
Yeah. We start with conditions that are, easily recognized and treated in childhood, like middle ear fluid. And these findings track their progression to potentially unrecognized, far more complex forms of hearing loss in adulthood.
So it forces us to stop thinking about these as temporary childhood problems.
Exactly. That you just grow out of. Instead, these studies encourage critical thinking about proactive, specialized, lifelong screening and management.
So it's not just about treating an infection when it pops up.
No, it's about anticipating complications decades down the road.
Okay, so to give you a comprehensive roadmap for this deep dive, we have drawn key information from 3 major, very recent research papers that, when you put them together, they provide this full lifespan picture. First, providing that crucial look at the adult experience, a perspective that has, historically been underrepresented in the research, we have Scheibler, ENMM et al. That's from 2024.
Right.
The title is Hearing Loss and History of Otolaryngological Conditions in Adults with Microdeletion 22Q 11.2. And this study, published in the American Journal of Medical Genetics Part A, it gives us the data we need to understand how these childhood issues can echo into later life.
Then we anchor our understanding of the pediatric side of things with 2 really strong contemporary studies. We have Liu and et al. From 2023.
And that title?
It's Otorhinologic Disorders in 22Q 11.2 Deletion Syndrome, and it was published in Otolaryngology Head and Neck Surgery. And this paper is particularly insightful because it specifically investigated the relationship between immune factors versus anatomical structure as drivers of ear and sinus disease in kids.
That's a huge question for families.
It is. And finally, we have a really detailed look at the spectrum of concurrent problems in childhood from Hack, S. and Madgarts. This one is slated for 2025, titled Otolaryngologic Disease in 22Q 11.2 Deletion Syndrome. Spectrum, co-occurrence, and outcomes in a contemporary pediatric cohort. It's in the European Archives of Otorhinology.
So a very contemporary look.
Very. It gives us a meticulous analysis of the entire ENT complex palate, hearing, and airway all at once in children.
So the main mission here for our deep dive is to synthesize this progression.
Exactly. We want to offer you a clear and actionable understanding of the complexity and the consistently high prevalence of these issues. And the key message we want to drive home is that these conditions are not isolated. They are multidimensional. They often overlap.
Like airway and palate issues happening together.
Right. And they absolutely require coordinated, specialized care that has to be considered long-term, well past the age of 18.
Okay, let's jump straight into the data. Let's start with the condition that defines the early years for so many in this community, hearing loss. We'll look at the story of hearing loss as an evolving challenge, starting with what the pediatric studies tell us.
When we look at children with 22Q 11.2 DS, the sheer prevalence of hearing issues is, well, it's staggering, and it demands immediate attention.
How staggering are we talking?
The Hack study, which reviewed a contemporary pediatric cohort, found that hearing loss affected an enormous 74% of the children they examined.
Wow, 74%. So it's not a risk, it's practically an expectation.
It is. And the type of hearing loss seen in childhood is very specific, which is good because it gives us a target for intervention.
Okay.
The sources confirm that the overwhelming majority of hearing loss in children is classified as conductive hearing loss.
Okay, conductive hearing loss. Can you break that down for our listeners?
Yeah, absolutely. So think of the ear like a plumbing system.
Okay.
Conductive loss means the plumbing is blocked, or the mechanisms designed to carry the sound aren't working efficiently. The inner ear, the wiring, is usually fine at this stage, but sound simply isn't being conducted effectively through the middle ear to reach it.
Got it. So it's a mechanical problem, not a nerve problem at this age.
Exactly. The primary culprit blocking this plumbing is usually chronic otitis media with effusion, or cum, which is persistent fluid buildup behind the eardrum.
That glue ear we hear about.
That's the one. Or recurrent acute otitis mediarum, which are those frequent, often painful middle ear infections. The Eliez study found recurrent acute otitis media in 42.2% of the children they looked at.
And all that fluid,
Yeah.
it just dampens the sound.
It does. It disrupts the sound transmission by dampening the vibrations of the tiny bones, the ossicles. In the hack cohort, 46% specifically experienced this conductive hearing loss.
And if we zoom in on the root cause of that fluid buildup, it's often linked to the eustachian tube, right?
That's right, eustachian tube dysfunction. These tubes are supposed to ventilate the middle ear, equalizing pressure and draining fluid down the throat.
But they don't work properly in many individuals with 22q.
Exactly. The craniofacial structure and the characteristic muscle hypotonia or low muscle tone in 22q, 11.2ds often affect the muscles responsible for opening and closing the eustachian tube.
So the muscles are just not strong enough to do the job.
Precisely. If those muscles don't work effectively, the tube stays closed, creating a vacuum that pulls fluid from the surrounding tissue. It leads to persistent effusions or allows infection to set in. It's a mechanical failure, a perpetual traffic jam in the middle ear tunnel.
And this high rate of infection and chronic fluid naturally leads to what we call a high surgical burden for these children.
It does.
Tympanostomy tube placement. Inserting those small ventilation tubes to bypass the dysfunctional eustachian tube and drain the fluid is extremely common.
Extremely. The Eliez study reported tube placement in 38.3% of their cohort, and Hack's paper reported 28% having tubes.
But the challenge, and I think this is specific to 22q 11.2ds, is the persistence of the problem.
Yes. The underlying issue, the structural problem, it doesn't just go away because a tube is inserted.
Yeah.
So we see high rates of repeat procedures. The Eliez study noted that 24.2% of their patients required multiple sets of tubes.
Almost a quarter needing them again.
And the Hack study similarly reported 10% of their cohort needed repeat insertions. This makes managing middle ear issues a long-term strategy, requiring vigilance over many years.
And the complication rate is also worth pausing on, because this informs the kind of expertise you need.
It does. The Eliez study highlighted a really significant issue: the rate of persistent tympanic membrane perforation requiring repair.
So the hole from the tube doesn't heal on its own.
Right. The hole left when the tube came out did not heal naturally. That rate was 12.2% among the children who received tubes.
And how does that compare to the general population?
Well, they point out that this perforation rate is about twice the high end of the published rate for the general population.
Twice. That's a crucial, actionable finding.
It really is. It tells families and clinicians that surgical outcomes for ear tubes in 22q 11.2ds may be inherently less predictable. They carry a higher risk profile for persistent damage, suggesting the need for specialized, vigilant follow-up and perhaps, selecting surgeons highly experienced in this specific population.
Okay, so in childhood, we have a clear picture. Prevalent, frequent, mostly conductive hearing loss, driven by these structural and functional issues in the middle ear. And this demands frequent and, as we just heard, higher risk surgical intervention.
Huh.
But now we have to transition to the Scheibler study to see what happens when these children become adults.
And this is where the story of hearing loss gets fundamentally more complex.
Tell us about that study.
So the Scheibler study looked at 60 adults with a median age of 25, and their findings emphatically state that hearing loss is not something that resolves when an individual grows up.
Doesn't just go away?
Not at all. The prevalence remains incredibly high, found in 78.3% of the adults in at least one ear. And the data gets starker. 65% had hearing loss in their better hearing ear.
65%. That's a huge number for your good ear.
It is. But as you said, the key distinction is the shift in the type of loss. While the majority of children face conductive loss, that plumbing problem, the predominant type of loss in adults, according to Scheibler, is often high-frequency sensorineural hearing loss.
So we've moved from a plumbing problem to a wiring problem.
Exactly. It's in the inner ear, the cochlea. This shift suggests either an ongoing degenerative process or an inherent vulnerability in those inner ear structures.
How common was this type of loss?
Scheibler specifically noted that of the adults with hearing loss that could be classified, sensorineural loss was the most common type, observed in 66.7% of those cases.
And that's critical because sensorineural loss is permanent.
It is, and it requires completely different intervention strategies like hearing aids rather than just tubes or surgery.
Let's dedicate a moment to detailing what this high-frequency sensorineural loss actually means for daily communication and quality of life, because this seems to be the unrecognized component that causes so much social frustration.
It truly is. High-frequency sounds are the highest-pitched sounds. Think of consonants like sis, gives, the K, and sh.
The sounds that give speech its clarity.
Exactly, it's crispness. If you have this type of loss, you can often hear the vowels, the volume, but you lose the details. It sounds like people are mumbling, especially when there's any kind of background noise.
So a restaurant, a classroom, a busy office.
All become incredibly difficult. The stress of constantly trying to distinguish speech amidst noise becomes exhausting.
And how many of the adults in the study had this specific type of loss?
Scheibler noted that 41.7% of the adults studied had hearing loss limited only to these high frequencies in their better hearing ear.
It was very specific.
Very specific. And since standard generalized audiometry often doesn't test up to the crucial 8 kilohertz range, this loss just goes undetected for years.
And the implications of that are, well, they're profound.
They are. Unrecognized hearing loss, especially the kind that impairs speech discrimination, can lead directly to anxiety, social isolation, reduced educational and employment opportunities, just general mental fatigue.
If you're constantly straining to follow a conversation, you start to withdraw.
You do. This is why that finding 65% of adults with hearing loss in their better ear is a massive call to action for proactive screening.
Okay, this sounds like a perfect feedback loop. The hearing loss causes stress, and that stress impacts overall health. So let's look at the connection. What did Scheibler's team find about what predicted the severity of this adult hearing loss?
They tested a few things: age, sex, and a history of chronic otitis media. And the analysis revealed 2 significant predictive factors. First, higher age was linked to more severe hearing loss, which, is expected.
Right, that happens to everyone to some degree.
But the critical finding, the link that closes the loop between childhood and adulthood, was that a history of chronic otitis media was also a significant predictor of hearing loss severity in adults.
I want to focus on that. So, a plumbing issue from decades ago is now predicting the severity of an inner ear wiring problem today. What's the mechanism there? What does the paper suggest might be happening?
That is the central question. The paper suggests that chronic inflammation in the middle ear, caused by those persistent infections and fluid, even if it's resolved, might lead to biochemical changes that affect the delicate structures of the cochlea over time.
So the inflammation itself does the damage.
Potentially. The repeated trauma and inflammation may sensitize or weaken the inner ear. They also raise the possibility of congenital inner ear abnormalities that are not fully expressed until later in life, perhaps made worse by the chronic middle ear issues.
And there's a genetic component too.
Yes. They also note that the genetic factors involved in 22q11.2DS, particularly genes like TBX1, are known to play a role in cochlear development. It's possible that the underlying genetic vulnerability makes the inner ear structurally weaker or more susceptible to this kind of degeneration.
That completely reframes how we should think about managing childhood ear infections.
It does.
It's not just about stopping immediate pain or getting through an infection.
No, it's a potential decades-long health protection strategy. Aggressively managing that middle ear fluid in childhood could literally protect the inner ear integrity in adulthood.
It underscores the critical need for vigilance, viewing it through a lens of long-term preservation, not just immediate relief.
Exactly.
Okay, that covers the hearing pathway. Now let's pivot to our second deep dive, which covers the complex interplay of the palate, speech, and airway. And for this, we're drawing heavily on the comprehensive pediatric studies by Hack and Liu. Let's start with the palatal picture and the challenge of velopharyngeal dysfunction, or VPD.
Right. So palatal anomalies are a well-known defining feature of 22q11.2DS. The Hack study confirms this, reporting that structural or functional palatal anomalies were present in nearly 2/3 of the children in their cohort.
And we have to remember that palatal anomaly is a spectrum.
It is. Hack specified overt cleft palate in 16% of patients and submucous cleft palate, which is hidden under the mucous membrane and harder to spot in 20%.
And then there's the functional challenge, VPD. Can you break that down?
Yeah. So velopharyngeal dysfunction is the inability of the soft palate, that valve at the back of the throat, to close off the nasal cavity during speech.
And that leads to that characteristic hypernasal speech.
Exactly, where air escapes through the nose when it shouldn't. Hack found VPD in 36% of the pediatric cohort.
Now, here's what I think is the most critical finding in this area. The thing that should change clinical practice immediately.
The VPD beyond the visible cleft.
Exactly. The Hack study revealed that nearly 1 in 5 children, 18%, with no structural palatal anomaly, still exhibited functional VPD.
That's a game changer. It means relying solely on a physical examination for a cleft palate is insufficient.
Right, so even if a child's palate looks structurally perfect,
Their soft palate muscle function, which is tied to the low muscle tone and specific craniofacial differences, may still be compromised, causing functional speech difficulty.
which emphasizes that you need specialized functional assessment.
Precisely. It usually involves a speech evaluation by an expert speech pathologist, and sometimes imaging studies like nasopharyngoscopy. We have to screen for the function, not just the structure.
And this complexity clearly impacts speech outcomes. What did the Hack study find about the severity of speech delay?
They found that moderate or severe speech delay was observed in over 40% of the pediatric cohort.
40%.
Yeah, and this high rate translates into the necessity for intense, ongoing intervention. This is demonstrated by the high rate of speech therapy. 66% of children in that study received therapy at some point.
So 2/3 of the kids needed speech therapy.
That's right.
We often talk about palate surgery as the primary fix. But given that VPD can be functional, not just structural, does the research suggest that surgery alone completely solves the problem?
Not entirely, which is a powerful lesson in the complexity of 22q11.2 DS. While palate surgery is essential for correcting the underlying anatomy in those with structural issues, Hack's data showed that having palate surgery resulted in only a modest, non-significant reduction in moderate or severe speech delay.
A non-significant reduction.
Yeah.
That's a subtle but really important finding.
It is.
It suggests that while the anatomical fix is necessary, the speech problem is also driven by other factors.
Absolutely. The speech challenges are complex and multifaceted. They reflect the additional impact of neuromotor, cognitive, and developmental components inherent in 22q11.2 DS, which surgery alone can't fix.
So the therapy needs to address more than just the resonance from the open palate.
Yes. The persistent need for speech and language therapy, even after a technically successful surgery, echoes this complex interplay. The therapy needs to address articulation deficits, motor planning, and global language development.
So speech therapy isn't just something you do while waiting for surgery.
No, it's a necessary, long-term, specialized intervention that must run concurrently with any anatomical correction. The goal isn't just a physical fix, but developmental catch-up.
Moving beyond the mouth and nose, let's discuss the findings around the airway and sleep. We frequently hear about breathing difficulties and sleep apnea concerns.
Yes, airway abnormalities are another significant challenge. The Hack study, using detailed endoscopic assessment, found that more than half of the children showed at least one airway abnormality.
What kind of abnormalities?
Things that affect breathing structure, like laryngomalacia, which is a softening of the voice box tissues that causes them to collapse, and subglottic stenosis, which is a narrowing of the airway below the vocal cords.
The presence of these underlying airway issues must create a difficult trade-off, especially when planning that palate surgery we just discussed.
It creates an essential clinical dilemma. Any procedure meant to tighten the palate to fix VPD, like a pharyngoplasty, works by intentionally making the back of the throat smaller.
To restrict nasal airflow during speech.
Exactly. But if a child already has a compromised or narrowed airway, tightening the palate can push them over the edge into severe breathing distress.
So the surgeon has to know the full airway status before operating on the palate?
Absolutely. This is why coordinated multidisciplinary planning is non-negotiable. The Hack authors highlight this. The team needs to balance the goal of improving speech against the absolute priority of maintaining a safe airway.
And regarding sleep, what did the sources reveal about obstructive sleep apnea, or OSA?
The Liu study reported a significantly higher than average prevalence of OSA in children who had a sleep study 18.8%.
And how does that compare to the general pediatric population?
It's much higher. Rates are usually between 0 and about 5 or 6%, so this is a major finding. OSA isn't just snoring. In children, it impacts concentration, behavior, and growth.
This persists into adulthood.
It does. Scheibler also noted that OSA is a persisting condition that affects adults, found in 8.3% of their older cohort. The causes in children are often driven by anatomical obstruction.
Okay, that brings us to something I found really powerful and clarifying for families. We know immunodeficiency is often associated with 22q. Did the Eliez study find a link between low immune cell counts and all these recurrent ear or sinus infections?
This is one of the most compelling pieces of data from the Eliez study, and it offers important clarity. They investigated the role of immunodeficiency, specifically low counts of immune cells or antibodies.
And what did they find?
Well, they confirmed that low immune cell counts are present in a significant portion of the cohort.
Okay.
However, and this is the vital part, when they ran a statistical analysis to see what factor was the strongest predictor of ear issues, the immune factors were not significantly associated with increased odds of recurrent ear infection or the need for tube placement.
So if the immune system isn't the primary driver, what is?
The Eliez study found that cleft and palatal anomalies were the only variable significantly associated with increased odds of recurrent ear infection and tube placement.
That is a profound conclusion.
It is. It strongly suggests that anatomical structure, specifically the craniofacial and soft palate differences leading to that eustachian tube dysfunction, plays the major overriding role in driving otologic disease.
That's a massive relief for parents, I think.
I guess so too.
It shifts the primary focus away from a generalized immune failure, which feels frightening and systemic, toward a manageable anatomical problem.
It allows the treatment strategy to be centered correctly. You focus on the mechanical or anatomical solutions, like tubes, to manage the chronic fluid, rather than constantly worrying about systemic immune deficiency as the root cause of every earache.
Okay, this analysis provides such a deep and nuanced picture. Let's synthesize this and extract the practical, actionable takeaways and recommendations that you, the listener, can apply and discuss with your healthcare team immediately.
This really raises the ultimate question: what do we do with all this data? These findings provide a mandate for proactive, comprehensive care that is adjusted as the individual ages. We have to move beyond just managing acute problems.
And shift toward anticipatory, lifelong surveillance.
Exactly.
Let's start with the most dramatic finding. That shift in hearing loss type in adulthood. What should be the absolute priority for screening?
Recommendation 1. Lifelong audiologic surveillance focused on high frequencies. Based directly on the Scheibler findings, we strongly support the recommendation for periodic, specialized audiometric screening, say, every 5 years, for all adults with 22q11.2ds starting in young adulthood.
This needs to be built into the standard adult care protocol.
It does.
And we established that standard screening isn't enough. What's the crucial detail families need to know?
They must specifically request that the audiologist test high-frequency ranges up to 8 kilohertz. You should be asking, are you testing the 6 kilohertz and 8 kilohertz thresholds?
Because standard tests often stop lower.
They do, maybe at 4 kilohertz. And since the adult hearing loss is often limited to those high frequencies, it is easily missed entirely, leaving that 65% of adults with an unrecognized disability.
And early identification allows for interventions.
Timely interventions like custom high-frequency hearing aids or assistive listening devices. These can be transformative. They don't just restore volume, they restore the clarity necessary for successful social interaction. It reduces the cognitive load, the anxiety, the social isolation. It can directly translate into better outcomes in employment, education, and mental health.
Okay, a very practical and specific action item. Ask for high-frequency testing, up to 8 kilohertz.
Exactly. Now, moving on to speech and structure, our second recommendation.
Recommendation 2. Comprehensive functional ENT checks and airway awareness.
Right. Given the HACC study's finding that nearly 1 in 5 children with no visible structural anomalies still had functional DPD, we need to ensure all children receive functional speech and VPD assessments,
regardless of whether they have an obvious cleft or not.
That's the key. This means pediatric ENT specialists need to use specialized techniques like nasopharyngoscopy to assess function, not just appearance.
And it means early, specialized speech therapy is essential.
It is, and it has to be viewed as a long-term neurological and motor intervention, not a quick fix before surgery. Furthermore, clinicians and families have to remain vigilant about airway health, especially if surgery for VPD is being considered. You must ensure the surgical team has assessed the airway beforehand.
And this comprehensive check should continue into adulthood.
Absolutely. The Scheibler study highlighted conditions like OSA, balance issues, and globus pharyngeus. We recommend adults receive a comprehensive otolaryngological and audiological exam at least once. If there's chronic snoring, get a sleep study. If there are balance problems, screen for vestibular dysfunction.
Okay. And our third recommendation has to tie the childhood experience back to the adult risk.
Recommendation 3. Prioritize early, specialized, and aggressive management of otitis media. We saw that powerful link between a history of chronic otitis media and later, more severe sensorineural hearing loss in adults. This means continued vigilance for ear infections in childhood is crucial for long-term cochlear health.
And given that anatomical factors are the strongest drivers, how should families adjust their expectations for interventions like ear tubes?
Families should be counseled that surgical outcomes for tubes may be less predictable and carry a higher risk profile for problems, specifically that perforation of the eardrum.
So you need a specialist.
You need to seek out specialized ENT surgeons who have experience with the unique anatomy and healing characteristics of 22q 11.2ds. It's not a routine procedure in this population. It requires specialized care and rigorous follow-up.
So what does this all mean when we wrap it up?
It means empowering ourselves with 3 core pieces of knowledge.
First, that ear issues don't end in childhood, they just change form. So you need that specialized adult screening for high-frequency loss.
Second, that speech challenges are multifaceted, requiring functional assessment and long-term therapy even without a clear physical cleft.
And third, that anatomical structure, not immune failure, is the primary driver of ear disease, which allows us to focus treatment effectively.
And if you look at the high complication rate for perforations, it means even routine surgeries in 22q 11.2ds require specialized expertise. Knowledge of this complexity is vital for advocacy.
This deep dive into the complex and evolving picture of otolaryngologic health in 22q 11.2ds has been incredibly informative and, I hope, highly actionable.
I hope so too.
This deep dive, What's New in 22q, is brought to you by 22q11 Europe, the European Association supporting families living with 22q11 deletion syndrome. We are dedicated to translating the latest research into practical knowledge for you.
And as a final provocative thought, given that the most common form of adult hearing loss in this population is hidden in those high-frequency ranges and so significantly impacts communication, consider initiating that conversation with your healthcare team this week about high-frequency audiometry up to 8 kilohertz for the adults in your family.
Don't wait for them to complain of a profound loss.
Exactly. It is a simple diagnostic step with profound long-term implications for their social engagement, their independence, and their overall quality of life.
Thank you for listening to What's New in 22q, produced by Dr. Stephan Eliez for 22q11 Europe. Take care and talk to you soon.